Imagine, uh, imagine you are the chief architect of a massive walled city. You've been given a finite number of bricks,
Right.
and the citizens are demanding a fortress to keep them safe, a state-of-the-art hospital to heal the sick, a school system to educate the young, and, I don't know, a bridge to connect the trade routes.
But you cannot build them all at once?
Exactly. You must weigh what matters most to the survival and the flourishing of your city. That agonizing balancing act, that is the scale, it is the inescapable reality of priority setting.
Yeah, but your job doesn't end there, does it?
No, it doesn't. Because once that hospital is built, you quickly realize you cannot possibly treat everyone. So you must decide who gets to enter the hospital before they even feel sick. You design a filter at the city gates, testing citizens as they walk through.
And that is the sieve.
That's the sieve, and that represents the complex, highly debated world of population screening.
I think that metaphor captures the exact reality of global public health so well, because public health is always, without exception, conducted under constraint. No country, regardless of its wealth or its political system, can fund every beneficial intervention. We just can't. We cannot treat every condition at maximal intensity, nor can we eliminate all risks simultaneously. The whole discipline of priority setting emerges from this very friction.
Which is why today we are building a mental framework for you. We're going to decode the ethics of how resources are allocated to scale and then apply those ethics to the messy, mathematical, and often really dangerous reality of population screening, the sieve.
This is a deep dive into chapters 3.5 and 11.4 of the Oxford textbook of global public health.
Consider this an essential survival guide for your clinical and public health reasoning. And a quick reminder, you should read the Oxford chapter alongside this deep dive. This is a companion, not a replacement.
Right.
The ultimate takeaway we want you to have is that you must stop thinking of medical decisions as purely technical. They are inherently political, and they are deeply moral.
Yeah, and the pressure on the system is compounding rapidly right now. We are sitting in what health planners call a perfect storm of rising healthcare costs. If you look at the macro framework, the inevitability of constraint is driven by a few massive intersecting forces.
Let's unpack those forces.
First, we have an aging population. People are living longer, which is a triumph, obviously, but it means a much larger demographic requiring complex, long-term care. Second, rising citizen expectations.
Meaning people just expect more from their health systems today.
Exactly. They expect a higher quality of life and better health services than previous generations did. And third, hyper-expensive technological and pharmaceutical innovations.
I want to dig into that innovation piece because it really feels like a double-edged sword. On one hand, we have these miraculous, highly targeted treatments. Take Novo-7, for example.
Right, the recombinant coagulation factor.
Yeah, used for hemophilia. It is an absolute lifesaver for a very small group of patients, but the cost per case is astronomical. We're talking massive resources for one individual.
And then on the other side of the spectrum, you have drugs like statins.
Exactly. A single statin pill is incredibly cheap, pennies. But because we prescribe them for cardiovascular prevention to such a massive portion of the population, the aggregate cost to the health system is staggering. Both scenarios drain the finite pool of resources, just in entirely different ways.
To truly understand why this creates a crisis of prioritization, we need to look at a fundamental economic differentiation, the difference between public goods and private goods.
This is a crucial distinction for the listeners to grasp.
It really is. A pure public good is something like clean air, clean water, or a national sanitation infrastructure. These are non-competitive.
Meaning my enjoyment of clean air doesn't subtract from your ability to breathe it.
Exactly. No one is excluded, and the provision of the good raises general social well-being across the board.
So how does clinical medical care, like a hip replacement or a targeted cancer therapy, fit into this economic model?
Well, private goods in healthcare are inherently competitive. The resources, the surgeon's time, the hospital bed, the budget allocated to that hip replacement or that course of Novo-7, these are fundamentally taken away from another potential patient. It is a zero-sum game in a way that clean air is not.
But traditionally, public health has been seen as existing in that public good sphere, right? Preventing disease for everyone rather than treating individuals. How does this zero-sum game impact broad public health initiatives?
Because even those traditional public health measures cost money. Anti-smoking campaigns, stockpiling preventive medicines for a pandemic, running educational programs on obesity, they all require funding.
And that funding comes from the same pot.
Exactly. That funding is drawn from the exact same finite pool of national wealth as the budget for therapeutic clinical care. A dollar spent on a public health education campaign is a dollar not spent on a hip replacement. Priority setting is inescapable across the entire spectrum of health.
So if we have to choose, how do we actually decide what is good? How do different societies weigh these choices? Chapter 3.5 of the text outlines the architecture of choice, specifically the 5 content values.
These are the substantive ethical principles that societies use to build their healthcare systems.
Let's break these down, starting with the first two, which are usually grouped together: clinical effectiveness and cost effectiveness.
Clinical effectiveness is the foundational question. Does this intervention accomplish its clinical purpose better than existing alternatives? Does it provide greater health benefits? We obviously do not want to waste resources on procedures that do not work or that actively cause harm.
Cost effectiveness takes it a step further. It asks, is the difference in cost between this intervention and the alternative justified by the health benefits it produces?
Right. This is fundamentally about opportunity cost.
And when we talk about cost effectiveness, we inevitably crash into the concept of QALY's quality-adjusted life years. Walk me through how a health system actually calculates a QALY, because on paper it sounds incredibly abstract.
It can be abstract, but a QALY is essentially a metric used to measure the benefit of a healthcare intervention. It combines both the quantity of life lived and the quality of that life into a single index.
Okay, so how do the numbers work?
You assign a weight to a state of health. Perfect health is 1.0. Death is 0.0. If an intervention gives a patient an extra year of life, but they are in a state of severe pain or disability valued at 0.5, that intervention has generated half a QALY.
Proponents of QLOYs argue they are deeply impartial, right?
Mm-hmm.
Because a year of perfect health is valued exactly the same whether you are a CEO or a bus driver, young or old.
They do argue that, but the math gets controversial very quickly.
I mean, how do we objectively assign that 0.5 value to a health state? Is the quality of life of someone in a wheelchair inherently less than someone who can walk, simply because society hasn't built accessible infrastructure?
That's a massive critique of the QALY from disability advocates.
Right.
Furthermore, what happens when a health system adopts a purely maximizing approach?
Meaning they try to generate the absolute highest number of QALY for the population, regardless of who gets them.
Yes, that maximizing approach can lead to severe ethical blind spots.
Which brings us to the Oregon priority setting experiment in the United States, which seems like the ultimate cautionary tale for this. How did their strict maximizing approach actually play out?
In the early 1990s, Oregon attempted to rank Medicaid interventions strictly on cost effectiveness to maximize total health benefit. What they found was that mathematically, curing thousands of minor ailments like tooth capping for dental caries generated more aggregate quality than saving a handful of lives with highly expensive procedures like appendectomies or organ transplants.
So capping a tooth is very cheap, and it slightly improves quality of life.
Exactly. And you multiply that slight improvement by tens of thousands of people, and the total QALYs gain surpassed the QALYs gained from one very expensive, life-saving surgery.
Yet, denying life-saving care to fund dental work feels deeply counterintuitive to our moral compass. It just feels wrong.
Which means cost-effectiveness cannot exist in a vacuum. It must be balanced against the third content value, justice or equity.
The text defines the golden rule of justice as treat like cases as like and unlike cases as unlike. In healthcare, the likeness is usually the medical condition. Two people with the same cancer should have the same access to treatment. But what counts as a morally relevant difference to justify treating them differently?
This is where clinical practice meets philosophy. Consider two people who need a liver transplant, but one is 20 years old and the other is 80. Is age a morally relevant factor?
This introduces the fair innings argument, doesn't it?
Yes. The idea is that the 80-year-old has already had a fair share of life's experiences, their fair innings, whereas the 20-year-old has not. Therefore, prioritizing the younger patient might be viewed as a just distribution of scarce resources.
But others would argue that a life is a life, and age discrimination is inherently unjust. And what about personal responsibility? If one patient needs a lung transplant due to a genetic condition and another due to a lifetime of heavy smoking, is their personal behavior a morally relevant factor in allocating that scarce organ?
Different societies answer these questions very differently based on their underlying social contracts. Some systems prioritize absolute clinical need, while others weave in notions of societal contribution or personal responsibility.
That perfectly sets up the fourth value. Solidarity. This is the idea that society stands together, that we don't leave the sickest or the poorest behind. But what happens when the math tells us one thing, but our conscience tells us another? Let's look at the Thai adult diapers case from the textbook.
That case illustrates the brutal tension between solidarity and macroeconomics.
Here are the parameters for you. In Thailand, providing diapers for elderly and disabled individuals experiencing incontinence costs roughly $1,200 a year per person. In a country where the average income might be quite low, this is a massive, crushing financial burden on poor families.
So, ITAP Thailand's Health Intervention and Technology Assessment Program ran the numbers. They found that providing these diapers was actually highly cost-effective. It generated a massive improvement in quality of life for the patients and their caregivers, coming in at about $1,200 per QELY.
Which is well below Thailand's threshold for value for money. It hit the cost-effectiveness value perfectly, and it hit the solidarity value perfectly by supporting the most vulnerable. So why wasn't it funded?
Despite meeting all those criteria, the intervention was rejected for inclusion in the universal coverage package because of the sheer scale of the need.
The population multiplier.
Exactly. There were an estimated 360,000 people eligible. When you multiply $1,200 by 360,000, the total budget impact was simply unacceptably high, over $400 million. The health system could not absorb that cost without causing systemic financial ruin, forcing cuts to other vital services.
It's a stark realization. You can have an intervention that is effective, cost-effective, and deeply aligned with social solidarity, but if the finite bricks of the city wall just aren't there, the system cannot build it.
It contrasts sharply with a system like Sweden's, where the social value of solidarity is so deeply entrenched that it will often trump cost-effectiveness entirely. If there's a medical need, Swedish society historically believes it must be met, almost regardless of the cost per QALY.
Which brings us to the final content value, autonomy. This is the principle of self-direction in health. It is the freedom to choose your own healthcare path.
However, if a healthcare system relies heavily on autonomy, often seen in more market-based systems, it frequently leads to out-of-pocket top-ups. If you want a better hospital room, a faster scan, or a novel drug that the public system won't fund, you pay for it yourself.
The danger there is that maximizing autonomy fundamentally threatens justice and equity, because the wealthy get a completely different tier of
survival. Exactly. They get a different tier of survival than the poor.
So we have these 5 content values: clinical effectiveness, cost effectiveness, justice, solidarity, and autonomy. And they are constantly at war with each other. If these values are constantly contradicting each other, how do health systems actually make a final call?
We have to pivot to what the Oxford text calls process values. The philosopher Norman Daniels proposed a highly influential framework called accountability for reasonableness.
Let's unpack Daniels' framework.
He argued that because we will always disagree on the moral principles, the legitimacy of resource allocation relies entirely on a fair process. If the content is contested, the way we make the decision must be unassailable.
It relies on transparency, accountability, and participation. What does true transparency look like in a massive bureaucracy?
Transparency does not simply mean dumping a massive spreadsheet of clinical data onto a government website. That is what we call a flood of information, and it is often used to obscure rather than clarify.
Right. If no one can read it, it's not transparent.
Exactly. True transparency requires that the reasons and rationales for priority setting are intelligible and comprehensible to the public. If a cancer drug is denied funding, the public needs to understand exactly why in plain language.
What about accountability? It's not just about balancing the checkbook, is it?
No, decision makers must be accountable for the value judgments they are making. If a system decides to prioritize pediatric care over geriatric care, the leaders cannot hide behind algorithms. They must stand up and own that moral choice.
And participation. Who gets to have a voice in these decisions? I imagine there's a massive difference between asking a patient what they want versus asking a general citizen.
There is a fascinating tension between the patient perspective and the citizen perspective. If you only ask patients or patient advocacy groups, the perspective is understandably narrow. I have this disease. I want this drug funded right now.
Understandably so.
But the citizen perspective is broader. A citizen might say, I want that drug funded, but I also want a sustainable health system that will be there for my children in 20 years, and I want good roads, and I want a strong education system. A fair process must integrate both voices.
Let's look at how this plays out globally, because different countries prioritize these values differently. In the UK, you have NICE, the National Institute for Health and Care Excellence. They use explicit QALY thresholds. It is very math-driven, very public, and often very controversial.
Extremely controversial.
When NICE decided not to recommend the flu drug Relenza years ago, the manufacturer actually threatened to move their facilities out of the UK. Meanwhile, in Germany, their agency, IQWIG, operates under a totally different paradigm.
Germany has the famous Nicholas case from their constitutional court. This case essentially ruled that an individual physician's judgment of clinical need can, in certain circumstances, override strict cost-effectiveness.
Which places a much higher premium on the doctor-patient relationship and clinical autonomy than the utilitarian math of a QAY.
Yes. And in Latin America, we see a completely different mechanism, the tutelas. In countries like Colombia and Brazil, citizens use constitutional courts to enforce their fundamental right to health. If the public system denies them a treatment, they sue, and the courts often order the state to provide it.
And we are reporting on this impartially, as it's laid out in the sources, but the unintended consequence of the tutela system is profound. While it provides accountability for the individual, the cumulative effect actually skews equity.
Usually, it is the wealthier, better-educated citizens who have the resources and the time to litigate. This means public funds are disproportionately diverted to pay for their court-ordered treatments, draining resources from the poorest who cannot access the legal system.
It is a perfect storm of ethics, economics, and law. We have built the architecture of the scale, we understand that resources are finite, and the choices are moral. Now, let's transition to the sieve.
Moving from the macro theory of priority setting to the ultimate high-stakes practice of population screening.
Why is screening considered the ultimate test of priority setting? Because you are allocating vast amounts of finite resources to test entirely healthy people.
This requires a crucial clinical differentiation, one that is often misunderstood even by experienced practitioners. We must separate population screening from opportunistic testing or case finding.
Let's draw a hard line here for the listeners, because using the wrong terminology clouds public health reasoning. Give me an example of the difference.
Population screening is a systematic public health service offered to a defined population who do not perceive themselves to be at risk. They think they are completely healthy. An example is sending a letter to every woman aged 50 to 70, inviting her for a mammogram.
Right. And opportunistic testing.
Opportunistic testing, or case finding, is when a clinician systematically applies tests to existing patients. If you are an endocrinologist and you check all your diabetic patients annually for retinal disease, that is case finding. You are testing people who already have a known pathology.
Or if you test someone who comes into the clinic with a cough for a specific infectious disease, that is diagnostic testing. Screening is uniquely defined by searching for hidden disease in an asymptomatic population.
The history of this is fascinating. It started gaining traction in the 1940s with mass miniature radiography to find tuberculosis. But today, it is morphed into a massive commercialized enterprise.
Fueled by private clinics and a very understandable human fear of mortality, there is this immense public demand for early diagnosis. We have this deeply ingrained belief that finding something early is always better.
But public health pioneers Cochrane and Holland issued a stark warning about this mindset. They emphasize that population screening is uniquely dangerous compared to almost any other form of healthcare because the healthcare provider initiates it.
That's the key difference. When a patient comes to a doctor with a broken arm, the patient is asking for help. The doctor responds. But in screening, the doctor is sending a letter to a healthy person sitting happily in their living room saying, "Come in, let me test you."
By initiating that contact, the provider is making an implicit promise. Undergoing this test will benefit you. But the reality is that screening programs can, and often do, cause profound harm. We are talking about overdiagnosis, overtreatment of questionable abnormalities, the psychological devastation of false positives, false reassurance from false negatives, and the physical hazards of the tests themselves.
You are intervening in the lives of healthy people, so the ethical bar to prove that you are doing more good than harm must be incredibly high.
Which means we are doing math, but we are doing math with human lives. Let's break down the mechanics of the sieve. Any test has two vital characteristics: sensitivity and specificity.
Clinicians are naturally wired to care most about sensitivity. They are terrified of missing a case and sending a sick person home. But in population screening, that mindset is actually dangerous. Walk me through the math. Why is specificity king in screening?
Sensitivity is the proportion of people with the disease who correctly test positive. Specificity is the proportion of people without the disease who correctly test negative. In a hospital diagnostic setting, high sensitivity is crucial.
But in population screening, you're testing tens of thousands, maybe millions of healthy people.
Exactly. If your specificity is even slightly off, let's say it has a 5% false positive rate, when you multiply that by 1 million healthy people, you suddenly have 50,000 terrified healthy citizens flooding your hospitals for biopsies and invasive follow-up tests. A high false positive rate will completely destroy a screening program's acceptability, bankrupt the system, and cause untold psychological damage.
This introduces the concept of positive predictive value, or PPV. The PPV asks, if a patient gets a positive test result, what is the actual percentage chance that they truly have the disease? Run the numbers for me, because this is the trap so many junior doctors fall into when they look at test specs. They assume a perfect test in the lab translates to a perfect test in a low-prevalence clinic.
The mathematical reality that trips up many people is that TPV relies heavily on the prevalence of the disease in the population you are testing. Let's look at the thalassemia MCH test example from the Oxford text.
Okay, set the scene.
Let's say you use a mean cell hemoglobin cutoff of 27 picograms to detect beta thalassemia carriers. If you run this test in a specific London hospital that serves a population with a high prevalence of the gene, the sensitivity is 100% and the positive predictive value is 77.4%.
That means if the test rings the alarm, there's a roughly 3 in 4 chance the person is actually a carrier.
But watch what happens to the math when you change the geography. If you take that exact same test, the same machines, the same chemical reagents, the same 100% sensitivity, and you move it to a region with a very low prevalence of thalassemia, the positive predictive value plummets to 1.3%.
Wait, 1.3? That's incredible. You can have a technically perfect test, but just because of where you administer it, the test will generate 98 false alarms for every one true case it finds.
Yes. You will recall 98 healthy people, terrify them, and subject them to further testing, just to find one real case. You cannot simply parachute a screening test from a high-prevalence hospital ward into a low-prevalence general population.
To rescue specificity in these situations, the text mentions combining tests and using ROC curves. Remind us exactly how an ROC curve visualizes that trade-off between sensitivity and specificity.
An ROC curve, or receiver operating characteristic curve, is a graphical plot that illustrates the diagnostic ability of a binary classifier system as its discrimination threshold is varied. It plots the true positive rate against the false positive rate. By looking at the curve, public health planners can choose the exact cutoff point for a test that maximizes true positives while keeping false positives at a manageable level for that specific population.
Alternatively, you can combine the initial blood test with a demographic questionnaire about family origins to increase the likelihood ratio. Screening is not a diagnostic test. It is simply a sorting mechanism separating populations into high probability and low probability groups.
We evaluate cost effectiveness before launching these programs, but there are massive hidden costs. Let's look at the abdominal aortic aneurysm, or AAA, screening program. What did the initial models miss?
The AAA example is a classic lesson in the knowing-doing gap and the underestimation of complex systems. When researchers initially modeled the cost-effectiveness of an AAA screening program, they typically just looked at the short-term hospital costs of an ultrasound versus the cost of treating a ruptured aorta.
But implementing a national screening program is vastly more complicated than just buying ultrasound machines.
It's so much more. They ignored the massive hidden infrastructure costs. You need bespoke IT systems to track millions of people. You need fail-safe mechanisms so no one gets lost to follow up. You need to send out tens of thousands of invitation letters.
And you have to pay for the primary care appointments of all the screen positives who are now anxious and require counseling. You have to maintain a massive network of quality-assured staff.
And the most fascinating part of the AAA story is the shifting epidemiology. The original randomized controlled trials that proved AAA screening was cost-effective were conducted back when smoking rates were much higher. Smoking is a massive risk factor for AAA. The mathematical models assumed a high prevalence of aneurysms.
But by the time the UK actually implemented the national program years later, aggressive anti-smoking public health campaigns had worked wonderfully. The prevalence of AAA had plummeted.
Which is a massive public health victory, but it meant that the pre-evaluation assumptions for the screening program were entirely out of date. Because the disease was now rarer, The screening program was suddenly catching far fewer cases, utterly destroying the assumed cost-effectiveness of the massive infrastructure they had just built.
This highlights the knowing-doing gap perfectly. Sometimes when a government wants to invest in a shiny new national screening program to show they are doing something, the actual most cost-effective intervention isn't a new program at all.
Right, it might just be fixing the current primary care pathway. It might be better case finding by GPs or optimizing the treatment of people who are already symptomatic, rather than spending millions hunting for asymptomatic people.
Let's bring this back to the ethics of the civ. We established earlier that priority setting is governed by social values like equity and autonomy. How do these manifest in population screening? Regarding equity, we often see a deeply unequal uptake. Middle-class and higher socioeconomic populations generally utilize screening services more frequently than disadvantaged groups.
This creates a paradox. A public health intervention designed to improve population health can simultaneously widen health inequalities.
We also see equity weaponized in strange ways. The text notes that some men's advocacy groups have lobbied aggressively for national prostate cancer screening programs. Their argument isn't necessarily based on clinical efficiency, but on a skewed version of fairness.
Arguing that since women have breast and cervical screening programs, men deserve a prostate screening program to match, even though the evidence for blanket prostate screening in asymptomatic men is highly contested.
Then there is the value of autonomy, which relies entirely on informed consent. But does the public truly understand the statistics of screening? Most public messaging simply says, screening saves lives. It rarely explains the number needed to screen.
According to a 1998 study by Rembold on breast cancer, to prevent one single death from breast cancer, you have to screen 2,451 women aged 50 to 59 over a 5-year period. Over 2,000 women must undergo the anxiety, the radiation, the potential false positives, the biopsies, just to save one life.
When you frame it that way, informed consent looks very different. To understand why the benefit is so diffuse, we have to look at two fundamental epidemiological biases inherent in screening: length time bias and lead time bias.
Let's start with length time bias. How does that work?
Length time bias occurs because screening is episodic, say, every 3 years. Imagine throwing a net into a river every few hours. You are highly likely to catch the slow-moving fish, but the fast-moving fish will swim past between casts.
So in screening, you are highly likely to catch slow-growing, relatively benign tumors that might never have killed the patient.
Exactly. Fast-growing, highly aggressive, lethal cancers tend to pop up and become symptomatic between screening rounds. They are called interval cancers. So screening artificially looks incredibly successful because it catches all the good cancers that weren't going to kill you anyway.
Lead time bias is even more deceptive. Imagine 2 trains leaving a station. One train represents waiting for symptoms. The patient is diagnosed at age 58, lives 2 years in treatment, and dies at 60. Now imagine the second train represents screening. We find the cancer early, at age 52. The patient still dies at age 60 because the treatment doesn't cure this specific aggressive tumor.
The screening hasn't extended their life by a single day. All it has done is extend the time they live, knowing they have a terminal disease from 2 years to 8 years. Statistically, survival time from diagnosis looks vastly improved, 8 years instead of 2, but actual mortality hasn't budged.
There is one more ethical shadow we must acknowledge, particularly as we move into the era of genetic screening. When we begin population-level carrier screening or non-invasive prenatal testing, we overlap uncomfortably with the historical specter of eugenics.
Modern genetic screening is rooted in providing parents with informed reproductive choices. However, the societal implications of systematically identifying and potentially selecting against certain genetic traits raise profound, uncomfortable questions about what kind of human variations a society values or seeks to eliminate.
Because the stakes are so high, we need rigorous governance. The UK uses the National Screening Committee, built on the classic Wilson and Jungner criteria from 1968. This framework demands that before you screen, the condition must be an important health problem. You must have a highly precise test, but crucially, you must already have the treatment pathways and fail-safe IT systems fully optimized and in place.
If you find a disease but don't have the hospital beds to treat it, your screening program is unethical.
But the most difficult political act in all of public health is not starting a screening program. It is de-implementation. It is stopping a program that is already running.
This brings us to what Raffel and Gray call the popularity paradox. The paradox is this: the more a screening program overdiagnoses harmless, slow-growing cancers, the more survivors it creates.
You have an army of people who had a benign tumor removed, and they genuinely, passionately believe the screening program saved their lives. Trying to shut down a screening program is like trying to bulldoze a beloved public park because an engineer found a minor structural flaw. The political optics are terrible.
If new evidence emerges proving the program is causing more harm than good through surgical complications and anxiety, the government tries to shut it down. Immediately, they are faced with fierce backlash from thousands of vocal, emotionally invested survivors, patient advocacy groups, and the commercial entities that manufacture the testing equipment. It becomes politically toxic to defund.
The Japanese child neuroblastoma screening program is the ultimate case study here. They started screening infants for this rare tumor in 1985. By 1990, an international panel reviewed the data and found the screening did absolutely nothing to reduce mortality, but it was causing massive harm through unnecessary surgeries on infants for tumors that would have regressed naturally.
Knowing it was harming children, it took the Japanese government until 2014 years later to officially stop the program. The only reason they succeeded in closing it down was because the disease was so rare that there were no fierce commercial lobbies or massive parental advocacy groups fighting to keep it alive. If it had been a common adult cancer, it might never have been stopped.
Let's break down how this actually looks across a lifespan, because the approach to screening shifts dramatically depending on the age of the patient. Let's start with antenatal and newborn screening. We frequently hear about PKU. For the junior doctors listening, remind us what that entails.
PKU, or phenylketonuria, is a rare inherited disorder that causes an amino acid called phenylalanine to build up in the body. It is detected using the newborn heel prick blood spot test. This is an example of highly effective screening because if it is caught early, severe intellectual disability can be entirely prevented through a strict diet.
However, this level of screening opens complex debates about carrier status. Should we inform parents if a child is merely a carrier for a disease, even if the child will never develop symptoms? This information can cause profound anxiety and alter family dynamics.
Moving into adulthood, the landscape becomes much more commercialized. Patients frequently come into clinics demanding tests like the PSA or the FOBT.
PSA stands for prostate-specific antigen, a blood test used primarily to screen for prostate cancer. FOBT is the fecal occult blood test, used to check for hidden blood in the stool, a potential sign of colorectal cancer.
The clinical controversies here are fierce. With PSA testing, the evidence largely advises against blanket screening for asymptomatic men because it frequently leads to biopsies and treatments for slow-growing cancers that would never have caused harm, resulting in incontinence and impotence. Yet the commercial demand and public advocacy for the test remain incredibly high.
Finally, we must look at how screening changes for the elderly population. In geriatrics, the paradigm is shifting away from population screening entirely. Instead of sending out mass letters inviting healthy 85-year-olds for cancer screenings where the competing risks of mortality often outweigh the benefits of early detection, public health is moving back toward opportunistic case finding.
So relying on routine GP visits to actively look for frailty, falls risk, and social isolation. It's a completely different public health mechanism tailored to the reality of the patient's life stage.
To tie this entire deep dive together, whether we are looking at the scale of priority setting or the sieve of population screening, the core truth remains. Resources are finite. Numbers, QALYs, and likelihood ratios can guide our decisions, but they can never replace our values.
Priority setting ultimately reflects what a society fundamentally believes health is for, and precisely whose health it believes counts.
When we choose what to screen for and what to fund, we are essentially writing our society's moral autobiography in real time. In 100 years, when medical historians look back at our resource allocations, at exactly who we put through the sieve and who we turned away at the city gates, what will they say about the values we actually held compared to the values we loudly claim to hold? It is something to mull over the next time you order a test.
That's a powerful thought to end on.
All right, time to solidify those frameworks. Here are your rapid-fire recall prompts. I'll read the question, take a second to think, and the expert will break down the answer. Prompt 1. You systematically check all your diabetic patients annually for signs of retinal disease. Is this an example of population screening, opportunistic testing, or case finding?
This is case finding or systematic testing, not population screening. Screening applies to populations who do not presume themselves to be at risk. You can review Chapter 11.4, Concepts in Screening, for consolidation.
Prompt 2. In a cost-effectiveness analysis using QALYs, which priority setting value is most heavily emphasized, Autonomy, justice, or efficiency?
Efficiency. QALYs seek to maximize total health benefit for the population, which can sometimes conflict with justice or equity. This is covered in Chapter 3.5, Cost Effectiveness.
Prompt 3. You implement a highly sensitive test for a very rare disease. Will your positive predictive value, or PPV, be high or low?
Low. Because the disease prevalence is rare, the sheer volume of false positives will outnumber the true positives, destroying your PPV. Specificity is critical here. Review Chapter 11.4, Properties of Screening Tests.
Prompt 4. A screening program detects a high volume of slow-growing, benign tumors, leading patients to credit the program with saving their lives, making the program impossible to defund. What is this phenomenon called?
The popularity paradox. Overdiagnosis breeds intense public loyalty, complicating the political reality of priority setting and de-implementation. See Chapter 11.4, Evaluating, Restricting, and Stopping Existing Programs.
Prompt 5. According to Daniel's accountability for reasonableness model, simply publishing a massive spreadsheet of health data satisfies the process value of transparency. True or false?
False. Mere disclosure is a flood of information. True transparency requires the reasons and criteria for priority setting to be intelligible and comprehensible to the public. You can revisit Chapter 3.5, The Process of Decision-Making.
Prompt 6. Which epidemiological bias explains why a screening program might appear to drastically improve survival time from diagnosis without actually changing the age at which the patient dies?
Lead time bias. The screening merely extends the time the patient lives knowing they have the disease, artificially inflating survival statistics without reducing mortality. Review Chapter 11.4, Bias in Evaluating Screening.
Here are the details of this episode.
Priority setting, social values, and public health. Byline. When everything matters, how do we choose?